thank you. I appreciate that. But looks to me like we have a fair number of people sleeping in today right now. After all, it is a sleep conference, so you know, if you're getting your sleep, that's good too. So I wanted to talk about non-invasive ventilation for chronic respiratory failure this morning, and this is something I've been doing for many, many years and have a lot of interest in this topic. Today, this is a broader topic than what I'm going to cover, but because time is limited, I'm going to focus on two major areas in the use of non-invasive ventilation for chronic respiratory failure, and these are the major areas, the biggest diagnoses that we deal with. I noticed that when Dr. Chong was talking about obesity yesterday, he showed a map of the United States, and tucked in the corner, reduced in size, was Alaska, but there were certain areas of Alaska, and actually a substantial portion, where the obesity rates were greater than 30%, and so you certainly see people with the obesity hypoventilation syndrome here, and how you manage these people, you know, remains a challenge, and I wanted to show you some of the more recent information on that. And also chronic respiratory failure and COPD. The use of non-invasive ventilation has been quite controversial for several decades, and there is some recent data that certainly comments on its use, but probably will remain controversial. So we'll cover those two topics. Now, as far as obesity hypoventilation is concerned, as everybody knows, we are having an obesity epidemic in the United States and Western Europe. Other parts of the world see this as well. 2/3 of the US population is overweight or obese, and between 1986 and 2000, the proportion of people who are morbidly obese, i.e. with BMIs greater than 40 rather than 30, which is what defines obesity, has tripled. And since 2000, there has been a little further increase, although there's been some plateauing, although I think it was Dr. Javahiri that pointed out that although the percentage of people who are obese has remained at about 1/3, up to maybe 36% in Mississippi, which I think has the highest rate, the weight of the people who are obese actually has gone up some. So we're seeing more morbidly and super obese, those with BMIs over 50. Now, the obesity hypoventilation syndrome is defined as obesity, obviously, daytime hypercapnia, PCO2 greater than 45, and people sometimes throw in base excess and a bicarbonate that's elevated above normal, and no other identifiable cause. That doesn't mean people can't have a little bit of airway obstruction, but they can't have enough airway obstruction to explain why they're hypoventilating. Obesity hypoventilation is very common. Exactly how common it is in the obese population is not known because the appropriate epidemiologic studies have not been done, but several studies have demonstrated that if you look at obese people admitted to the hospital, about 1/3 of them have obesity hypoventilation syndrome, and I see it missed all the time on our wards when these very obese people come in. Bicarbs are up, nobody gets a blood gas, they're treated like anybody else, and often people don't even look for sleep apnea in this patient. So it's important to be aware of it, and therapy can be extremely helpful in keeping these people healthier and helping them survive longer. Now, we don't have good epidemiologic data in the United States, at least that I'm aware of, to tell us what's been happening over time with the use of non-invasive ventilation for various forms of chronic respiratory failure. But this study from Switzerland that was published just about 10 years ago in Chest, I think, is relevant. We probably do have the same experience. And so what they've stacked up in these bars here are various forms of causes for chronic respiratory failure, use of non-invasive ventilation. And you can see some of the typical things we've seen in the past, but these are being dwarfed by the main two diagnoses. But neuromuscular disease, I'm actually going to talk about that later on this afternoon. But look at the one that has been increasing more than any other in the gray here, and that is obesity hypoventilation. So now in Switzerland, the #1 reason that you put people on non-invasive ventilation for chronic respiratory failure is obesity hypoventilation syndrome, and I am certain it's the same in the United States. You'll notice that COPD is down here on the bottom, and it also has been increasing. Whether the United States looks like that or not, I'm not certain. Reimbursement issues, which we'll get into a little bit, dictate what happens. We heard all about that yesterday, and CMS, the Centers for Medicare and Medicaid Services, has been cracking down over the last 15 years ago on use in people with COPD. So obesity is not good for breathing. I think everybody knows this, but why is that? Well, there are a number of physiologic reasons, but first of all, the adipose load that people have around their chest walls lowers their FRC, and this increases the occurrence of ventilation perfusion abnormalities. And this is because when your FRC is low, you drop below the closing volume of your lungs, meaning a lot of your alveoli are actually closed at the end of expiration. And so this means that especially at the bases of your lungs, if you're upright, there are hypoventilated alveoli that are contributing to ventilation throughout the respiratory cycle, just the normal tidal breathing. And so ventilation perfusion ratios are low in those alveoli that are spending much of their time closed while these obese people are breathing, and that lowers PO2. And this clearly is positional. There are drops in oxygenation when you lie supine, for example, so it can be intensified during sleep. We all know that sleep apnea is very common in this population, and this contributes to respiratory problems, and that will be a lot of the focus of the talk today. Obesity hypoventilation, and I'll show you in the next couple of slides some of the physiologic data that we have on these patients. But more than 90% of patients with obesity hypoventilation have sleep apnea. Not every single patient does. There is a tiny proportion of patients who don't actually have frank sleep apnea, but the vast majority do. And this is associated with a blunted respiratory drive. And also, yesterday we talked about pulmonary hypertension in OSA, but cor pulmonale is a very common cause for presentation to hospitals in patients with obesity hypoventilation, related often to chronic hypoxemia, so they get vasoconstriction and remodeling of vessels, and then pulmonary hypertension on that basis. And then they start retaining fluid, they go into right heart failure, and this eventually tips them over to the point where they either go to the hospital or they die. And when we treat these people in the hospital, often they come in quite ill and may need to be intubated, and when we correct their fluid volume and blow off their CO2, they're often retaining CO2, enormous amounts of CO2, we can stabilize them and then get them onto non-invasive. Now, the blunted respiratory drive probably is not inherited in most patients with obstructive sleep apnea, which seems to be in contradistinction to patients with COPD, where first-degree relatives have been shown to have blunted respiratory drives compared to COPD relatives of COPD patients who are not retaining CO2, but this has not been the case in obesity hypoventilation. And so the first-degree relatives who are of normal weight don't have evidence of blunted drives. And also, when patients with obesity hypoventilation are ventilated non-invasively so that you blow off the CO2, the drive actually corrects, and you can show an increase in the slope of the CO2 response curve, indicating an increase in drive. So it is acquired, it is reversible in most cases. Now, one interesting study looking at the physiology of patients with obesity hypoventilation is oft quoted. This by Pankow, published in the European Respiratory Journal in '97, and they looked at patients who were morbidly obese. They had similar BMIs, but they identified patients who they termed had simple obesity, meaning they were large but did not have sleep apnea or obesity hypoventilation. Then they had a group, this is small numbers, but they had those who just had sleep apnea plus their obesity, but no obesity hypoventilation. And then they had a third group who were the obesity hypoventilators. And so as I pointed out, the BMIs are quite similar. The obesity hypoventilation patients had lower forced vital capacities. So even though they were similar in size, for some reason, their lung, or at least their vital capacities, were reduced compared to the others. And by definition, they were retaining more CO2, their obesity hypoventilators, and concomitantly, they were more hypoxemic. And this is partly related to their hypoventilation and probably partly related to some more ventilation perfusion mismatching. And the people who had sleep apnea and obesity hypoventilation had very, very elevated apnea-hypopnea indices, but it was about the same in those who had sleep apnea without CO2 retention and those who did. Now, when they put these patients on BiPAP, pressures 9/4, which are kind of low pressures, and looked at the responses, some interesting things came out. And they were looking at transdiaphragmatic pressures when they did this. They had manometry balloons in the esophagus and in the stomach, and they were looking at the pressure difference that was generated as an index of diaphragm activity. So if you had simple obesity and you went on BiPAP or sleep apnea alone, you did have an improvement in your vital tidal volume, but no real change in your respiratory frequency, a little bit of a decrease in the sleep apnea patients, and no change in end-tidal CO2, which would indicate that your respiratory rate had to have gone down a little bit to maintain the same end-tidal CO2. So your tidal volume goes up a little bit, your frequency goes down a little bit, you maintain the same CO2, and your transdiaphragmatic pressure goes down a little bit. But if you have obesity hypoventilation, these effects are magnified proportionately. You have a much bigger increase in tidal volume, a significant drop in your respiratory rate. You drop your CO2, so your center is telling you breathe a little more as opposed to these other patients. And look at the difference in the PDI. There was a drop in both of the others, but the PDI at rest was much, much higher and then dropped in response to the non-invasive ventilation. And so these are people who have more impedance to breathing for some reason. The PDI of 65, much greater than the others, indicates that these people are working harder to breathe. And this is undoubtedly magnified when they're asleep. And there may be a variety of reasons for that. They may have a little bit of underlying parenchymal lung disease, or maybe the distribution of obesity is different, but they have more impedance to breathing, so their load to breathe is higher, and this is probably what happens, that over time their breathing during sleep is more difficult, and their respiratory centers are willing to compromise and let their CO2s rise rather than drive breathing to the point of exhaustion. Now, non-invasive ventilation clearly does work for obesity hypoventilation. And this is data from that same Switzerland report that I showed you the epidemiologic data from, but they broke it down into the different settings, and they found that we had 71 patients with obesity hypoventilation that they followed over a number of years, average age 64, average BMI 42. The IPAP settings were 18/7, and this is probably pretty typical of the settings we see compared to a lot of the neuromuscular patients I see. The 18 is a little on the high side. And one other thing to note is that the delta here, 18/7, is greater than 10. And the literature suggests that if you want to adequately ventilate these people, this delta has to be in this range at least, because the difference between the inspiratory and the expiratory is your pressure support. That's the amount that's blowing your lungs open, so to speak, you know, when you inhale. And that's the amount of respiratory assistance you're going to get with breathing. So one of the mistakes I see made when these people come into a lab and get titrated or get sent out is that people focus on getting rid of respiratory events, and maybe you get rid of your hypopneas at 8 and your apnea is at 12 or something, and you send them out with 12/8. That is probably not going to be adequate for a lot of these patients. I'll show some data about this later. If they need significant help in ventilating. So this kind of difference is typical. Backup rate is usually stuck in there, at least when the Europeans do this. Average duration 6.2 hours, which is pretty good. Adherence rate 79%, which is outstanding. But these people really do feel better if they are adequately ventilated. PCO2s normalized, and the hospital days from before to after are significantly reduced. And this is over quite a number of years of follow-ups. And so, they had a very successful experience with non-invasive. And the studies also show that non-invasive is as effective at improving gas exchange in obesity hypoventilation. And this is a study from Spain, where they had a group of patients with obesity hypoventilation and those with kyphoscoliosis. And we've known for quite some time that non-invasive ventilation is quite useful for restrictive thoracic disorders like kyphoscoliosis. And you can see that the PCO2s drop about the same, and oxygenation concomitantly improves about the same. So this study concluded that non-invasive ventilation, again, is pretty effective at improving gas exchange. And this was using either a volume-limited type of portable ventilator or a bilevel. Now, as far as the long-term follow-up of these patients is concerned, we have this study from CHEST, Crew, where there were 130 obesity hypoventilation patients followed for an average of 4.7 years. And there were 38 who were started acutely and 92 in a more stable state. And then the bottom line is that over this almost 5-year period, that about 20% of these patients died. Another 20% had stopped but were still alive, and 84 were being successfully treated. So this is kind of a real-life experience. These patients with chronic respiratory failure differ a little bit between the entities as to how successful you're likely to be with non-invasive, but here about 80% of the people who were still alive were still successfully using non-invasive, and that's quite good when you compare it to a COPD population, where in the US the success rates have been as low as 50% over a period of time, people continuing non-invasive. But probably not as good as neuromuscular disease patients, where you probably get up more like in the 90% range. And these are the survival curves. And so the overall population had a survival of about 80%, as we saw in the previous slide. And one of the things that was interesting about this was that the use of non-invasive ventilation was actually not an independent predictor of survival, but that's because, you know, virtually most of the people on non-invasive were surviving, and you had such a small population of non-invasive non-survivors, it didn't really pan out. But oxygen supplementation did. And oxygen supplementation, it's you know, you could either say that oxygen supplementation is a marker for people who are worse, which is, you know, reasonable supposition. Why were these people still on oxygen if they were on non-invasive? Because if you ventilate adequately, then non-invasive, by normalizing CO2, should enable you to maintain normal oxygenation unless you have some kind of gas exchange problem. And so these might mark the patients who have underlying gas exchange problems, did not normalize their PO2s on non-invasive, and thus are sicker and are more apt to die. But another interpretation is maybe there is something dangerous about putting these people on oxygen. And that may be one of the contributors to this. In fact, there was a recent study in chest, recent within the last few years, by a fellow by the name of Wishiga or something like that. But what was interesting about that study was they put obesity hypoventilators on 100% O2 for 20 minutes and monitored what happened to their transcutaneous CO2. And there were 10 patients, I'm sorry, there were 24 patients in the study, but there were approximately 5 who had increases in transcutaneous CO2 greater than 10 millimeters of mercury. And we've known for a long time that there are some people who are very sensitive to oxygen and will hypoventilate when they're put on oxygen if they're in chronic respiratory failure. And so you have to be very careful putting some of these people on oxygen. Most of the patients did not have that response, but there was a small proportion that did, and those might be the ones who are apt to end up here if you're not careful. Now, one of the controversies has been you start out with CPAP and then go to non-invasive if it doesn't work, or do you just start out with non-invasive because you'll probably get more people captured and successful initially. So one of the earlier articles that looked at and compared the two was by Berger et al. And this was not a randomized controlled trial, but they had a small group of patients who were started on CPAP alone or on ventilation, and what here they mean sys control, but you could probably substitute BiPAP here because you can probably achieve the same ends. But the people put on CPAP had a significant drop in their PCO2s over time during follow-up, and so did the patients on ventilation, and there really wasn't any difference between the two groups. Again, this is not a randomized controlled trial, so you can't draw too many conclusions from this, but you could generate the hypothesis that starting out, it probably doesn't make a whole lot of difference as to whether you put people on CPAP or non-invasive ventilation. So that was one of the earlier observations. Now, that was in a group of patients who had obesity hypoventilation, but were naive to any kind of non-invasive approach. So what about people who are put on non-invasive and we compare simple sleep apnea to obesity hypoventilators? Is there any difference in their CO2 responsiveness there? And also, this study looked at the super obese, the BMIs greater than 50. So it's a tougher population to manage. You know, they have considerably more chest wall impedance. So they identified 23 patients that fell into these groups, 23 each. They had roughly comparable BMIs. The degree of airway obstruction was a little bit greater in the obesity hypoventilators, but pretty close. This was not statistically significantly different. The blood gases were significantly different, as you might expect, because the obesity hypoventilators had a higher PCO2 and a lower PO2. And so what they found was that the patients who had obesity, or rather obstructive sleep apnea alone, pretty uniformly had substantial improvements with CPAP. So these are this is total sleep time, and the percentage of patients, the percent of time that was spent with an O2 sat less than 90%. So at the start, most of these patients in the OSA group actually did not desaturate below or had greater than 20% below 90% SaO2 during the night. You can see, most of them are down here but certainly below 20%, many below 10%, as opposed to the obesity hypoventilators over here, who didn't have very many patients. Most of them were desaturating a whole lot at night, and so they go on CPAP alone. CPAP titrated to normalized inspiratory airflow, and the obesity or the OSA patients alone, the ones who were above that 20% of the night, dropped to the 20% range or below, and there were just a couple of outliers. Whereas with the obesity hypoventilators, many of them had improvements, but 43% ended up still with at saturations below 90%, more than 20% of the night. And so their conclusion was that the CPAP doesn't seem to be as effective at reducing desaturations at night in the obesity hypoventilators as opposed to the OSA alone group, but that they were still successful in the majority of patients. And so an approach that they suggested was maybe you start out with CPAP, which they said is cheaper, and then you go to BiPAP if you're not getting a substantial improvement. This group would go on to BiPAP. So that would be one possible approach. Now, what about those CPAP failures? Now, here is a study, again, widely quoted, looking at the use of AVAPs, or average volume assured pressure support, in patients with CPAP failures. This was a German study, and what they did was identify those patients who would have been at that 43% from the previous study, and then randomize them to go on BiPAP ST alone, or average volume assured pressure support, which I know many people in the audience are probably familiar with this, but in brief, rather than have a fixed inspiratory pressure and a fixed expiratory pressure with AVAPs, you give the ventilator a range of pressures to select, and the ventilator will vary pressure in order to achieve a target minute volume. And because you plug in a rate, it's actually a tidal volume that it's targeting. But it assures you, theoretically, a target ventilation, unlike the standard BiPAP ST. And so they had 10 patients. They were super obese or morbidly obese, rather, on average. Average age about 54. Transcutaneous CO2 nocturnally was 58 millimeters of mercury, and they did not have significant airway obstruction. So this was a pretty good obesity hypoventilation population. The BiPAP ST, they set up to pressure of 20. The average in the study was 14.7, so that's your IPAP. And then the EPAP, they varied from 4 to 8. Average was 6.1 in the BiPAP ST group. In the AVAPs group, they set the AVAPs to go from the expiratory pressure up to 30. So the ventilator could decide what pressure it wanted to achieve the target volume. And the average EPAP was 5.4, and the backup rate was about 17 in both groups. And in both, there was an improvement in sleep quality compared to no assistance at all, no surprise, but there was no difference between the two. And also for health-related quality of life, both improved over no treatment at all, but they were similar. So there was no significant difference in sleep quality or health-related quality of life between the two. But what they did find was an improvement in CO2 in the AVAPS group compared to the BiPAP-ST, which was only a little bit better than CPAP alone. And one thing that was interesting also was that they did find a lot of variability in the inspiratory pressure for the APAPs, much greater than in the BiPAPs, and that of course illustrates that the machine is kicking the inspiratory pressure up and letting it go down depending on the patient's needs to maintain that volume. So, you know, it was doing what it was supposed to do. So did this really make a significant difference? Well, if you feel that having a lower CO2 might be good in other ways, perhaps, but, you know, in the things that affect how people feel, perhaps, the sleep quality and health-related quality of life, there were no differences. They didn't ask patients about how they felt on the two different modes. I would have liked it if they had done that. And the fact that the PCO2 was lower may reflect the fact that the difference between the 14.7 and the 6.1, which is 8.6 here, that's your pressure support, compares to an average of 11 for AVAPs. And you could ask, well, if we just cranked up the IPAP on the BiPAP-ST a little bit more, maybe we would have seen the same effect on PCO2. But anyway, you know, there is a lot of interest in AVAPs for these obesity hypoventilators because the ability to maintain that tidal volume, which may vary a fair amount when you have morbid or super obesity. So to summarize those findings, when you have respiratory failure in obesity hypoventilation, how should you start? I think the evidence suggests that you could start either with CPAP alone and see if you get success, or a bi-level, and you're more likely to get initial success. You know, that 43% that doesn't respond adequately to CPAP, you probably will capture a significant number of those, and so the initial success rate will probably be a little higher if you start with non-invasive. So some people would argue that CPAP is theoretically simpler and cheaper to use, which is arguably true with, you know, with the newer devices we have. BiPAP really is pretty inexpensive too. What about the role of oxygen? Well, I mentioned the study that suggested that oxygen may be dangerous to use, but if someone is on one of these devices and they're still hypoxemic, then certainly we can add oxygen, and as long as people are on some form of ventilatory assistance, they're not likely to develop dangerous hypercapnia. And so if someone is persistently hypoxemic despite being on CPAP or non-invasive, I certainly would add oxygen to maintain reasonable oxygenation overnight. And then over time, things may change. And in some of the studies we have, people have started out on non-invasive and have been able to transition to CPAP to sustain the improvement in ventilation. And finally, tracheostomy still may have an occasional role, but I certainly would go as far as I can with non-invasive routes. I don't know about people in the audience, what kind of experience they've had with trachs in morbidly obese people, but mine has not been terrific. You know, they get a lot of complications of the stoma and other issues. So the one other point to emphasize is that the pressures may need to be a bit higher in these obesity hypoventilators whose chest wall impedances are pretty high. Now, if you want to start, you have to satisfy the reimbursement guidelines, and so in general, they would like you to start on CPAP, and If there are sustained O2 desats, as in those 43% desaturators that I talked about, then after a period of, it's usually about 2 months, you can switch to a bi-level. And you have to be able to demonstrate that there's been a significant improvement by switching to bi-level, and you will get reimbursed. When you do that, the long-term survival, as I pointed out, is actually pretty good. This is about 90% in this study compared to 80% in the other ones, but the literature generally shows that patients who are responding well have pretty good survivals, and this is compared to other patients who are chronic hypoventilators. Now, I'd like to shift gears and move on to chronic respiratory failure in COPD patients. And number one, there has been a theory related to patients with COPD that one of the reasons they develop chronic CO2 retention is that their muscles are fatigued. And this is an illustration that one of my sisters, who's a medical illustrator, put together for me, but it's supposed to show that in people with severe COPD, especially if they have bullous emphysema, they have hyperinflated lungs, their diaphragms are flattened out, so the radius of curvature is greater and there's more tension of the diaphragm. And you can imagine how the Hoover sign occurs when this diaphragm contracts. It can actually pull the lower chest wall inward, so you get a paradoxical motion of you breathe in, and rather than chest wall moving out, the lower rib cage actually moves inward, which is opposite what it's supposed to do and is inefficient. And if you're normal, you can see the diaphragm is going to pull straight up and pull your ribs out like a bucket handle. And then your oxygen cost of breathing is much higher because you're using accessory muscles. The breathing is very inefficient. And also, this is supposed to show that you might have autopeep. And autopeep refers to the failure to empty the lungs completely at end expiration. And so you have positive pressure, i.e. autopeep, in your alveoli, which means that in order to bring air in for your next breath, you have to lower the pressure in the alveoli below atmospheric. So let's say you have 10 centimeters of water in that alveolus at the end of expiration. To bring in air for your next breath, you've got to lower that below 0, which would be the atmospheric pressure, so a delta of maybe -11 before you can begin your next breath. And lowering it is, we call an inspiratory load, or wasted effort, because no air is moving until you get the pressure down that low. So if you apply a CPAP in patients with that problem, all the patient has to do is lower the pressure below the CPAP level. So let's say we put someone on CPAP of 8 who has an autopeep of 10. All you have to do is lower the alveolar pressure to 7, and air will start coming in because it's being pushed in by that 8 in your mask of CPAP. And so you've lowered the work of breathing from having to bring it all the way down to -1, a delta of 11, to 7, which is only a delta of 3. So that's how end expiratory extrinsic PEEP, or CPAP in a mask can help reduce your work of breathing. We also know that people with COPD, we've known this for a long time, have sleep disordered breathing, don't sleep well. And on the left here, this is data from a little over 30 years now, but it's still relevant. And what it shows is that when it comes to sleep quality, people with COPD, whether they're on oxygen or not, which are the bars down here, compared to normals, have less REM, less slow wave sleep, less total sleep time, more fragmentation, and oxygen supplementation alone makes no difference. And so one of the theories is that by ventilating these people non-invasively at night, maybe you can improve sleep and perhaps rest the respiratory muscles that are being overworked. Now, we do know that when people fall asleep, the normal responses to sleep get magnified when you have the increased load of breathing. This is probably part of what it contributes to obesity hypoventilation, but it also contributes to COPD. And so when you fall asleep, there's an increase in upper airway resistance. It goes up even higher in REM. The tidal volume goes down, and this is magnified in COPD patients, actually a total of 35% on average in this study in COPD patients. Mild COPD does not have these effects. These are seen in people with severe COPD. And this is from Neil Douglas's work, but this is a sleep study showing that especially during REM, there are these big dips in oxygenation, and also the transcutaneous CO2s go up. And so they're, especially during REM sleep, when, as we learned yesterday, we are most vulnerable, there are these big effects on gas exchange. Whoops. And so hypoxemia is very common during sleep in COPD patients. It's not all associated with obstructive apneas, but a lot of them are related to hypoventilation, especially during REM, as I just pointed out. If you have daytime hypoxemia, that predisposes to even worse desaturations, and partly related to the slope of the oxyhemoglobin dissociation curve. If your PO2 is in the 60s range at rest on room air and you fall asleep and you start to hypoventilate, then you're at the steep portion of the curve, and it can really magnify the desaturations. These people also may have ventilation perfusion, and certainly some of these people have sleep apnea. Now, as I've mentioned in my introductory remarks, there's long been a controversy about how effective non-invasive ventilation really is in COPD, and up through the early 2000s, these studies illustrate the kind of controversy we saw. This was a study done out of England, in London. Meacham Jones was the first author, published in '95 in the American Journal of Respiratory Critical Care Medicine, the Blue Journal. And it was a very small crossover study which enrolled 18 patients. But what they found was there was a significant reduction in PCO2 during the 3 months that patients used non-invasive. The sleep time significantly improved, quality of life was better, and this was a highly positive study, and actually was the study that CMS used to come up with the current 52 cutoff. The average initial PCO2 was 56 in this study, and so the CMS wanted to use 56 as the cutoff. And I was actually on the phone conference when they were discussing this, and many of you know Neil McIntyre, but he was on the call, and he got them to go down to 52 by pointing out that there was a standard deviation, and you certainly didn't want to exclude the people who fell within the standard deviation, so he talked them down to 52, and that's how the current 52 happened. Now, this study was actually a study that we did when I was at Rhode Island, and it had completely the opposite result. We had a lot of dropouts. Patients didn't like it. We started out with 19 patients, more than they did, but only ended up with half as many. Our PCO2 started out at 46, and on average it actually went up a little bit. Our sleep quality, this was not statistically different, but it sure didn't get better like theirs did. We had one aspect of neuropsych testing that got better, but quality of life actually didn't. And yet our patients were more obstructed, but their patients had more hypopneas per hour. And so what people deduced from this was, one, it probably made a difference what your baseline CO2 was. Theirs was 10 higher. And so they had more hypoventilators. Ours were just marginally hypoventilating, even though ours were more obstructed. But they had more sleep disordered breathing. And so the idea, perhaps, is that those patients who have airway obstruction plus sleep disordered breathing, overlap syndrome, may be the ones who are actually more apt to respond. Now, this is data from that Meacham-Jones study showing the effect of oxygen alone, which was nothing on the patients in their trial, but when you added non-invasive ventilation, their oxygenation got better, and contrary-wise, their CO2s dropped and also improved when non-invasive was added. And they found a correlation between the drop in transcutaneous CO2 at night, shown here, and the improvement in daytime CO2. And so the better they did getting ventilated at night, it seemed, the better they did during the daytime. So about 10 years ago, putting this and a number of other studies together, the meta-analysis that was done showed no clinically or statistically significant effects on lung function, gas exchange, or sleep efficiency, a trend for a better 6-minute walk distance, and a positive effect on maximal inspiratory pressure, suggesting that maybe there is something to the respiratory muscle resting, but not a very compelling reason to use non-invasive ventilation. After that meta-analysis was done, there were a few other studies that were done. This was one study done out of Italy, where a total of 90 patients started out. Half of their patients dropped out or died, and so they ended up with a very small population, and they couldn't really show much that was very impressive. It looked like non-invasive ventilation prevented the increase in CO2 that they saw in their long-term oxygen therapy group alone. There was not a significant improvement in quality of life. This is a quality of life index here, but the deterioration that was seen in their control group didn't happen. So it looked like non-invasive ventilation maybe kept you stable, and there was a pretty strong trend toward reduced hospitalizations, and that might be one of the potential benefits. But really minimal benefits in that study. And so then the GOLD guidelines came out. I'm sure everybody's familiar with the GOLD, the Global Obstructive Lung Disease Guidelines. They were also underwhelmed. They said, given this conflicting evidence, long-term non-invasive cannot be recommended for the routine treatment of these patients. Nevertheless, you can combine it with oxygen therapy alone in a selected subgroup, particularly those with pronounced daytime hypercapnia. So they were willing to allow that there might be a subgroup where non-invasive ventilation could be more helpful. So we get to another randomized controlled trial out of Australia, published now about 5 years ago. And this was the largest study that had been done to date, but again, they had a high dropout. This is a big problem with all these studies. The COPD patients are unstable. They may have difficulty tolerating this, and so the dropout rates are high, which is a killer for randomized controlled trials. But despite that, they found a very slight signal for improved mortality, as shown here. This is the non-invasive, and this is the long-term. And you can see they're kind of coming together here, but they had to do an adjusted analysis, and they came up with a p-value less than 0.05, but it sure was unimpressive. Quality of life was actually worse. So if you want to believe that you extended life, it was at the cost of making people more miserable for that longer period of time. And the gas exchange changes were non-significant, totally unimpressive. But one thing was the IPAP pressure of 13/5 was kind of low, and people questioned whether they gave them enough ventilation at night. So in response to that, Wolfram Windisch in Germany came up with this idea of high-intensity non-invasive. He uses inspiratory pressures up to 40 with expiratory pressures, in the 5 to 10 range. So really high pressures. And in this particular study that he published in 2009 on 17 patients in Germany who started out with severe airway obstruction, hypercapnia, the mean IPAP in his study was 29 expiratory fork, and he compared it to 15/5. And he saw a large decrease in nocturnal PCO2. There was better compliance in the people on high pressure, surprising to me, and fewer dropouts, although there were more leaks. But one of the things he showed was that the PCO2, the high pressures compared to baseline, were much lower, and then he crossed these patients over, and the PCO2 and the crossover went back toward baseline. So clearly a big effect on gas exchange anyway. Now, the Cochrane group, most of you are familiar with the Cochrane group. This is an evidence-based medicine group. So after looking at all this data now, they said there's nothing to say that this does anything good. All this data is just a mishmash. It's all different trials. The dropout rates are too high. So the only time you should use this is in the context of a clinical trial. And this is at 2013, at a time when, not so much in the US, but in other parts of the world, some countries are using this like water. You know, many of their COPD patients are on non-invasive ventilation at night. So just within the last year, some interesting things have happened. One is published earlier this year, again out of the same German group that some of the who were on that high intensity study, randomized a group of patients. It's the largest study to date, 102 on non-invasive, 93 on long-term oxygen therapy controls, normal weight, early 60s, severe airway obstruction. This is gold stage 4 with severe CO2 retention, and they saw a greater drop in PCO2, an improvement in FEV1, a significant improvement in 6-minute walk distance, improvement in quality of life, and most impressively, these are the mortality statistics. And this is 33% mortality in the control group, 12% mortality in the non-invasive ventilation group. If every study was like this, we'd have everybody on non-invasive ventilation. My first reaction to this was too good to be true. I don't believe it. I just don't believe that everybody else who studied this, including me, didn't know what they were doing, and we couldn't come up with this, and yet, you know, here's what they have. But there are a couple issues with this study, and one really important one is they didn't do any sleep studies. And it's entirely possible, especially given the severity of CO2 retention, that a lot of these people have the overlap syndrome. And so what they're showing is when you give people who have sleep apnea and COPD non-invasive ventilation, the outcomes are better. And that's not a real big surprise, but unfortunately they didn't give any sleep study data. They said we couldn't do sleep studies because it would knock us out of the time windows for the study. It made no sense. I don't know how the reviewers approved that, but this study has gotten a lot of attention, and it may influence the reimbursement people. Now, one of the issues that we all face that I'm sure people know is the readmissions of COPD patients. A lot of hospitals are going to get fined for having too many readmissions, and COPD is one of those entities. So people are looking at the use of non-invasive ventilation to reduce readmission rates. And so this study out of Jerry Kreiner's group at Temple showed some really impressive improvements in readmission rates. So they did a retrospective study. This was not randomized, and they came up with 78 patients who had been discharged from Temple following respiratory failure due to COPD, and they were discharged on non-invasive, and then they had a group that was not placed on non-invasive for a variety of reasons. Sometimes they refused, or the doctors just didn't think of it, and so forth. They were reasonably well matched in terms of age and BMI and so forth. Severity of airway obstruction was even worse in the non-invasive ventilation group. One thing that's notable here is there was more obesity hypoventilation, OSA, which may have something to do with what I'll show you in a moment in terms of their outcomes. But in terms of readmissions, markedly reduced level of readmissions within 30 days, within 90 days, and also 180-day mortality halved in the people on non-invasive. So this is retrospective. It's not randomized. It can only be hypothesis generating, but it sure suggests there may be a signal for reduced readmissions. And this is their mortality, their survival rates, where on non-invasive ventilation, survival was much, much better. So looks pretty good. And then a few months later, this study was published, and this was out of the Netherlands, Struik and Thorax. And this was a randomized controlled trial, very, very well done trial, total of 201 patients, and they saw no difference in survival, readmissions, which were 64-65% over the subsequent year in both groups, arterial blood gases, or quality of life. So, you know, the retrospective one looks very, very promising. This showed absolutely no improvement whatsoever. And this is the drop in CO2s. And one thing that's interesting here is the dark is the non-invasive, and the gray is the standard therapy. And even though they did find a statistically significant difference here in terms of the delta, the amount that it drops. So this square is a little bit higher than that diamond, and that diamond is a little bit higher than the square. So the delta actually was statistically significantly different. But when you look at that, if I look at that, it looks pretty much the same. And so they identified the patients at the time of discharge because they were still retaining CO2, put them on non-invasive. But it shows you that over time, whether you're on non-invasive or not, your CO2 is going to drop as you improve. And so some people have said, well, that's the problem with this study. They should have waited and identified the patients who are still retaining CO2 maybe a couple of weeks or a month after their discharge, and maybe they would have seen something. So I told you that I'd go over a little bit of the reimbursement stuff, but if you want to put people on with COPD on non-invasive ventilation, this is that PCO2 of 52 that Neil McIntyre got us, which probably better than 56. They have this rule, sleep oximetry less than 88%, or less than or equal to 88% for 5 consecutive minutes on the usual FiO2. Where this came from, nobody knows. I was in a consensus conference to help CMS come up with guidelines in 1998 and actually wrote the section for COPD. So I've been blamed for this, but I swear I had nothing to do with it. They came up with this themselves, and it's been great to prevent people from going on non-invasive with COPD, which is why we don't use it as much. You don't have to do a sleep study to rule out OSA. They're willing to accept a testimonial. And then they require that you begin with an S mode. You can't have a backup rate unless you show the patient hasn't succeeded after 2 months. And then what's happening is people are now looking carefully at the codes, because you've got the RAD codes up here, the Respiratory Assist Device codes, and the 470 is the BiPAP S, which is what you have to start these patients on. And the EO471 you can switch to after 60 days. And the RADs are what are used for the typical BiPAP type device, and they're designed, according to CMS, for intermittent use. And obviously a lot of times it's going to be sleep apnea. And then they have the ventilator codes, the EO461, which is mainly a volume ventilator. There aren't that many around anymore because most are hybrids that offer pressure support. So it's really the EO464 that we're talking about. But the difference is these RAD codes they have a rental cap. You know, after 13 months of paying rental, the patient owns the device, whereas there is no cap here, and the monthly reimbursement is generally better. So what's happening is a lot of people are saying, this patient needs to go on a ventilator. You know, the study, the cone line study actually showed that the backup rate seemed to be important. And so a lot of people are trying to get patients on the EO464 code, which is a way of getting around the requirements for RADs that I just showed you, especially that 5 consecutive minutes of desaturation. But I suspect that CMS is going to alter this code a little bit because we're seeing a lot of people, certainly in the lower 48, doing that. I don't know if that's been going on here. So if you select patients with COPD, the adherence rates, as I said, are pretty low. And so you have to be very careful about what patient you select. I do believe that there is a population, especially CO2 retainers, who seem to do very well based on anecdotal experience with non-invasive ventilation. And these tend to be chronic CO2 retainers. Maybe they have the overlap syndrome, but they need to be motivated and cognitively intact. And maybe they're the people who don't tolerate O2 so well, they retain CO2, and they're in and out of the hospital frequently, the frequent flyers. Those are the group that seem to benefit. Now, we use non-invasive a lot for COPD exacerbations. It works well, there's no question about it. And some of those patients probably should be sent home on non-invasive. But if they get a little bit better and rip the mask off and say, get that out of here, I never want to see it again, that's probably not the patient who's going to succeed at home on non-invasive. You want somebody who's been able to tolerate it and is willing to work with it. So to summarize, obesity hypoventilation comprises mechanical and central defects, and obstructive sleep apnea is very prevalent in this group. They respond to non-invasive ventilation, but patients may also respond to a CPAP trial first, and whether you're the CPAP first type or the NIV first type, I don't think it really matters a whole lot. I tend to be the NIV first type because I just think we capture more people initially. NIV for severe stable COPD has been controversial due to conflicting data and will continue to be so. Recent data are encouraging. Probably it's best for these hypercapnics, people who have an overlap syndrome, who are motivated to try to master it. So I'll stop there and thank you very much. Do we have a moment for a question or two, Paul? I guess it's I either totally muddied everybody's minds there, or it's all clear.
Yeah, I'm Dr. Chung anyway. Say what?
Dr. Chung.
Oh, there he is.
Right on time.
Not working? Need that one? Here you go. Here, this one works.
Can you hear me?
Hey.
Yeah. Pointer's working.
Can you hear me?
Let's see, which one is it? It must be this one.
Can I borrow that for a sec? He wants to talk.
Okay.
For whatever reason. There you go.
My voice is not very good, otherwise I could. Can you hear me? Can you hear me?
Man. Where's our AV guy? You got it? Go ahead, try it now.
Can you hear me? Oh, yeah.
Yeah, there you go.
That's good.
Go ahead.
Yeah, Nick, that was a very good presentation. Thank you so much for that. But one thing you did not emphasize, Nick, which I like to emphasize here, is the importance of basal metabolic rate to daytime hypercapnia. You probably did not see the study we just published in the Annals of Thoracic Medicine. This was a very carefully done study in which I made sure a steady state is reached. Put lidocaine before I drew the blood gases. I had the patients breathe several minutes with a stable end tidal. And then I compared two groups of patients with obesity hypoventilation due to OSA to OSA patients without hypoventilation. They were matched for AHI. And of course, the group with OSA hypoventilation had a much higher BMI. And then I am calculating oxygen consumption and CO2 production. And indeed, CO2 production based on the alveolar ventilation equation, PaCO2 equal to CO2 production divided by alveolar ventilation. The overall ventilation was identical in both groups, but the CO2 production was significantly higher in the obesity hypoventilation patients and accounted for most of the daytime hypercapnia. When the CO2 production and oxygen consumption were corrected for BSA, the two values were not significantly different from each other. So really, one of the major determinants when you talk about the BQ mismatch and mechanisms of hypoxia, hypercapnia, the major mechanism when you compare morbidly obese people to non-obese people matched for obstructive sleep apnea is indeed CO2 production, which could account for most of the daytime hypercapnia. And of course, based on the Dalton's law, the reciprocal relationship between PaO2 and PaCO2, there will be significantly more hypoxemia. This is just published a couple of months ago, and I'll be glad to send it to you.
I did not see that. That was Annals of the American Thoracic Society or Annals of Thoracic Medicine?
Annals of Thoracic Respiratory Medicine, right.
American Thoracic Society, Annals of ATS. Okay. Well, that's very interesting. I guess it raises a couple of questions. One, why don't these people increase their minute volume to compensate? Two, why do they have an increased CO2 production in the first place? If their minute volume is the same, you couldn't say that the respiratory, although the Pankow study showed that the impedance is higher, and so their work of breathing for the same minute volume is higher, I guess, based on that. So that could be part of the component.
Right. So the main reason for excess CO2 production was the body weight. Yeah.
But they're the same size as the other people, right?
No, they were much more obese.
But the data that I showed you from the Pankow study, the obesity levels were the same.
Right. Very small.
It's a small study.
That is the 5, 7. I discussed that in the paper.